Okay, so in this one, we're going to talk about anticoagulation and different drugs that you can use. So heparin, usually it's 5,000 to 10,000 units. You can do that through your IV piggyback. Sometimes you can do IV push. It just depends on what your order is. You can do a drip. Then it starts to drip. Oh, so smart. For 10 to 15 days. The purpose is to minimize the growth and prevent new clots. So if you already have a clot, heparin's going to prevent it from getting bigger and also creating new clots. Monitor your PTT with this. Or anti-XA. I know she does like anti-XA because it's like newer and it's better, but PTT or anti-XA for heparin. Heparin, PTT, or anti-XA. Lovenox is the low molecular weight heparin. That's usually like 1 milligram per kilogram every 12 hours. SQ. Starts on day 3 of heparin therapy. So I think they start with heparin, and then you can go to the lower molecular weight. The purpose is to transition from heparin drip to oral anticoagulants for when they get sent home. Nursing interventions, monitor your platelet counts and monitor for bleeding. Use your soft brush toothbrushes or, all your nursing interventions for that. Antidote is protamine sulfate. She has it underlined. Antidote for heparin or Lovenox is protamine sulfate. If you're allergic to heparin, don't use it. HIT, heparin-induced thrombocytopenia. I think I'm saying that right. That is the antibodies that bind to heparin, and that results in your low platelets. So that's just like an adverse effect that can happen. Another one is warfarin. Warfarin, you need to watch your INR. So think about it as PTT or anti-XA as heparin, and warfarin is INR or your PT platelets. Okay, so your PTT and anti-XA is heparin, and warfarin is INR PT platelets. Usually it's 5 to 10 milligrams a day. Long-term anticoagulant, people get sent home on this all the time. Nursing interventions, again, INR, PT platelets. Monitor for bleeding and bruising. Patient education. So like your vitamin K, if you are going to take this and you're going to take a lot of vitamin K, the antidote is vitamin K. So you're not going to want to take a lot of vitamin K. Or different medications interactions. But the antidote for heparin or Lovenox is protamine sulfate. The antidote for warfarin is vitamin K. So the next slide shows you PTT, PT, INR ratios. So partial thromboplastin time, PTT. Your normal range is 20 to 30 seconds. Therapeutic range can be 1.5 to 2.5, and the normal is 30 to 40 for your clotting factors. So you're going to want your clotting factors, if the normal is 30 to 40 seconds, you're going to want to increase that time by 1.5 or 2.5. PT, so prothrombin time, the normal is 11 to 12.5 seconds, and then you're going to want to increase that as well by 1.5 to 2.5 of the normal. So for both, you're going to want, for PT and PTT, you're going to want to increase the time it takes to clot by 1.5 or 2.5. But for PTT, the normal range is 20 to 30 seconds, and for PT, the normal range is 11 to 12.5 seconds. INR, International Normalized Ratio, your normal range is 0.8 to 1, and then your therapeutic range is 2.5 to 3.0. You have reoccurring PEs, you're going to want that time to be 3.0 or 4.5. Just look at your platelets or your factor anti-XA levels as well. And then preventing injury while on anticoagulants. So discuss patient education with them. It says here that there's a chart 32.6. I'd take a look at it. Areas to assess for bleeding could be like stool, urine, drainage if they're vomiting, blood, they're bleeding in their GI tract somewhere, abdominal girth if they have like internal bleeding, you measure that, back pain, and then skin assessments. Just assess for bleeding in every way you can. And then nursing care, it says here again, chart 32.3 on page 606 in Iggy. I'd look at it. And then she also has chart 32.4 on 604. Genetic counseling can be taken a look at, like if people have like genetics, and you can like inherit blood or clotting factor diseases or different things. Like I know some people who don't clot, or some people who make clots too much, but genetic counseling you can always look into. Increased education for all families and patients with PEs or DVTs, and then monitor for injuries. And then she has a case study here. It's not a bad idea to look at it, but that is what I have for your gas exchange. And then just to mention it again, this is the homework I think that you guys had to do. It's not a bad idea to look over it again for your quiz. I know your quiz, you're either taking it or you already did take it by this time, but this could help for you for the exam as well. It just talks about everything that we just talked about. So I would look over that again. If you have any questions, again, Robin, I'm available, but Robin's your go-to because she's creating the tests. And then for next week, I will do one for chronic kidney disease, and I'll try and have it up by the end of this week. That way you guys can have like the weekend to look over it, because I'm not sure when your test is. But if you have any questions, just don't be afraid to email Robin or myself. Thanks. Okay.